I'd like to ask our local medical experts from Sonoma Valley Hospital, and we're so lucky to have a hospital that is affiliated with UCSF, and I think that has been really crucial. So I'd like to first start and ask Kelly Mather, the CEO, to come up, and then with her is Dr. Sabrina Kidd, who is our Chief Medical Officer. So I just really want to thank Kelly. We have been communicating constantly in the past week or so, and so just really appreciate the leadership of you and your team. And I think that's, so with that, I'll turn it to Kelly Mather.
Well, thank you for having me, and thank you, Kathy. We have, especially over the weekend, talked about every hour, so you have a very hardworking, as you know, city manager, and the team together, as I think we've pulled together very well. So we are on day 14 of our Incident Command Center being open. We were on the end of the curve as far as what was happening with COVID-19, again, not having any community transmissions announced until Saturday. Right now, most important, and I think you've all mentioned that you want to ask about testing, we do have 50 tests at the hospital. We have only used 9 of those tests. We only test people who are symptomatic. And Dr. Kidd, who I'll introduce next, will be able to answer any more specific questions about that. We at the hospital are in the midst of creating a cohort unit. It was our second floor of the hospital that was now closed and for outpatient services, but we are opening that for the patients that have either their rule out COVID or they are positive. Most hospitals will, if they have not already seen some COVID positive patients. Most of them are coming into the emergency department and going home with self-isolation. So we're not seeing that many severe, and that's happening with UCSF. Any other questions that I can answer, I'm happy to do, and then I'll bring Dr. Kidd up as well.
I wonder if we should hear from Dr. Kidd and then maybe come back with questions?
Yeah.
Is that, okay. Councilmember, sorry.
That's fine.
I'm Dr. Sabrina Kidd. Thank you for having us. I'm happy to answer any questions if you like. Some questions were sent to me ahead of time that were coming around. I can start with those and give you a few other updates and then answer any additional ones. One thing that I want to address before I go to the testing questions is I know a lot of information has been circulating in the communities. People have obviously been told to reach out, specifically call their primary care providers. We have been in close contact with those in the community. We have put together resources for them, including letters that are samples of what patients should do, and encourage them to personalize those and send those out to their individual patients, as they are essential to this process. We also have found basically on the spot set up telehealth platforms that they can use, and we are helping them with that as able. This is really, as Kathy mentioned, obviously we're taking all of our direction in as well from the CDC and the CDPH and other public health entities, and enacting those as well, and carrying out basically their orders and recommendations. As far as testing, this is obviously at the center of many people's questions. Why is there not a broader regimen in place? The biggest reason is the kits are not available. I know that is very hard to accept. That is not a situation that we're unique to. It is across the country. There's political reasons behind this, as we're all aware, but that is the reality. There are test kits available 2 different ways. One is through the Department of Public Health. Those are reserved for a certain class of patients. They consider these persons under investigation. They've given us a general criteria of when to notify, and these all include symptomatic patients. These do not include asymptomatic patients. So when patients come to us and they meet the criteria that we've been instructed to follow, if they meet the Department of Public Health criteria and we feel they need testing, we call the Department of Public Health and see if they approve that test. If so, we orchestrate that and get it sent, and the turnaround time on that has shortened to be around 24 hours, depending. It was longer at first, it's a little shorter now. It does vary depending on the time of day, pickups, etc. The other method that thankfully has been open up to us, but is still in process, is Quest or LabCorp started doing testing nationwide about a week ago now. It opened up last Monday, I believe. That testing is something we have to collect on our own. Quest sites cannot do any specimen collection on their own. It is up to facilities to collect those specimens, already have an existing lab account, arrange transport, and sending those to Quest to do. Those can be done outside the DPH, Department of Public Health specific guidelines, so they are broader. That helps us be able to test healthcare workers and other people that may have other reasons that are not the ones that the Department of Public Health is continuing to track. However, there are some limitations to this. Again, their supplies are limited, as is their lab resources and their turnaround time. They initially told us that turnaround time would be 3 to 4 days. We can tell you that it is at least 4 days at this point, and we do not know when that will improve. Not having, obviously, quick turnaround times limits the utility of this testing, as well as does the fact that the number of test kits available limits it. So we are working with those guidelines, trying to triage the most important people, and not as far as one person's life being more important, but their impact and contacts and whatnot to decide whom to test, following all of the guidelines that are coming out from the CDC and other sources with regards to this. When will more test kits become available? We do not necessarily know. We do know at this point we were being told we may get up to 10 available to us in addition each day. There are some other pockets that are maybes here and there, so it's a very fluid process. Of course, we are exploring all avenues and gladly taking what else we can get. Another big question is, why do we not have a drive-through type testing set up? Obviously, this has been well publicized that is thought to be part of South Korea's specifically success and low mortality rate is they know who has the disease. Our low incidence has been well publicized. Even in Sonoma County, is likely that we are not testing. Our county being lower may be that we are not testing. We do not have that information. We need to thus treat it like there is community spread because our neighbors have it. What are we doing to try and get a drive-by up? We are in active talks. We are working with the community health center. Again, this is a very resource limited as far as staff, people being told to isolate, etc. We do hope to have some version set up within a week, if hopefully less. But again, this will at this time be limited access based on symptoms and screening criteria because of the number of test kits. So what is the strategy for testing? We are following the following guidelines currently. 1, symptomatic patients with a known exposure. A known exposure is travel to a level 3 country or a confirmed case. Also, patients who are symptomatic but yet negative for other respiratory illnesses. Because of limited supplies, most protocols at this time are following the process of, if a person presents with symptoms, you first rule out the more common known diseases such as flu and respiratory syncytial virus and other things. And then those are very quick return times. Those are things we can do in-house. Therefore, after that information is obtained, we can proceed with COVID testing if indicated. We're also, like I said, unfortunately do not have the capacity to test for asymptomatic patients for the general public at this time. We all hope that changes, but at this time, that's where we're at. And I think those were the basics. Are there other questions I can answer?
I have a question. What are you preparing for in terms of the volume you expect to see at the hospital, and what are you doing to prepare for that?
As far as the volumes, it's completely unknown. At this point, I can tell you that I'm getting basically emails from colleagues in Washington State who say their hospitals are already overwhelmed, they're at capacity. The story of people's in hallways and not having adequate gowns, gloves, and masks is true, and that's in the United States. So redistributing resources is already a real issue in parts of our country. So we are really preparing for that scenario, and based on that, we are following the strictest WHO guidelines on reuse within appropriate measures of our goggles where we're allowed, our masks when we're allowed. We have followed the current CDC and WHO guidelines with kind of de-escalating the kind of mask that is needed, and except for certain what we call aerosolized procedures or active coughing patients, we are no longer needing an N95 mask. We're reserving those for the situations where it is absolutely necessary and not advising them a regular mask is sufficient for other situations. So because we are expecting or preparing for the complete unknown, we are 100% preparing for worst case scenario where we have very limited supplies and possibly out of beds. So as Kelly's mentioned, we are opening our second floor for capacity as well, which is an additional 25 beds locally, which is a lot.
What is the number that you're prepared to handle?
Right, yeah.
Well,
I knew that was what you're
yeah.
asking. Okay, so we can handle 39 inpatients right now. And right now, our census is 12. So some of those patients would be prioritized, meaning if they didn't need to be in the hospital, they could probably move to another site. Our skilled nursing facility is not taking any, as they should not, COVID patients at this time, but there are 27 beds there as well. So we actually have more capacity than a lot of hospitals.
Is there staff for that?
So again, a fluid question with, as of yesterday, and more recommendations coming of this, all elective surgical procedures are on hold or postponed. So we can pull staff from those areas, and that's what we're doing, is pulling people in as necessary. So we believe we will staff as best we are able.
Okay, I have two questions. One, what we've seen in other countries is they'll eventually set up kind of a COVID-specific wing where they're not. They allow nurses to continue working even if they've tested positive for the disease because they're treating patients that already have it. Is that something that the hospital has put in place? And then they have a separate wing where there's this for patients that don't have COVID, that then they're making sure the nurses are separated. Is that something that
So
exists?
we are already limiting personnel access to essential personnel only. We're repurposing a lot of things that are done by other staff. Nursing has the ability to also perform those duties, and so we are asking to minimize the number of people going into rooms through many different procedures. As far as what we call a cohort, which is putting everyone of the same disease in the same area, that is what we are preparing our second floor for. So yes, those are our plans. As far as allowing a person actually diagnosed with it to proceed, we have not really made a decision on that. However, it has been said that if a person is exposed and asymptomatic, they may continue to work.
Okay. Are there different locations within the community that are recognized as potential, like makeshift hospitals, say the Veterans Home or things like that? Is that, and if not, then is that just a ability of capacity of staffing that they have not been identified?
I'll let Kathy start, and then I'll jump in.
Yeah, so those really, there are discussions and work underway by the county for those types of things, and the specifics are kind of not determined, but clearly, you know, in my mind, the Vets Hall is a place that we are kind of preserving. The county closed all Vets Halls to activity about, I don't know, days are running away, a couple days ago. So that has been our go-to location. It makes sense in a lot of ways, but that is all to be determined. So, and then the governor, you know, clearly there's a much broader state impact here. There's a broader military support as well. And so I think what we're potentially going to see is, you know, the state coming in and kind of using, and national government as well assisting. So some of those things are still to be determined, but there is definitely planning initiatives and work underway.
Finally, how many beds will you have available for non-COVID patients that have just emergencies? Are we going to be able to keep a certain number of beds and doctors and things like that available?
So our third floor is going to be 24 beds, and that's what we're going to keep with non-COVID patients, and then the 18 for the COVID patients right now. That's our plan. Again, we'll see how it goes, but I do think that separating by floor makes more sense.
Are you reserving test kits for staff to ensure that your doctors and nurses have been tested?
Yes.
Good. Okay, thank you. Councilmember or Vice Mayor Hundley?
Great questions by my colleagues, but is there a chance that if a different area near us gets overwhelmed first, that they would send people to Sonoma Valley?
Yeah, definitely. The overflow, we've already talked with UCSF about options. And yeah, I mean, every hospital and our capacity, we're sending it in, and we're looking at where we can put patients first. So we're communicating as a state with California Hospital Association, and also communicating as a county as well.
So how does that work in terms of, you know, if it's just a timing thing and then this community becomes affected, but it's already full?
Right. Okay. So, well, Santa Clara County is a county that has had a cluster, and maybe Sabrina can jump in, and other hospitals are helping out. I mean, that's what we do. So we take the patients that are sickest first. We're not going to stop at county lines and say, stay here. If that's what you're asking, I don't believe we're going to do that.
No, I'm just wondering about sort of the timing, and if it could be that if Sonoma was slower than the others and that people here would be at a disadvantage because everything would be full or used up by then.
Okay, go ahead.
So I think the best way to answer that question is we don't know, but a larger way to think about this is that, and if you look at worldwide, most other countries besides Italy and here that are ahead of us in the curve, what you're seeing is remember that when one place spikes, another one improves. Most people recover from this disease, so we now are passing that break point in many places, and we hope that if we flatten the curve correctly, the same would happen here. That if we help out our neighbors, they'll be able to help us, because then by the time we're in need, they will have beds. That's the natural course of this disease that we're seeing worldwide, and I would hope that would pan out here. But again, everything is statistical models at this time.
And this is probably an impossible question, but just based on what we're learning from other locations, is there like a general sort of time frame for the bump that as it happens?
So the predictions are that it still has not reached our area yet. That's why we are really increasing to prevent it and still possibly have the opportunity to flatten this curve, as you've heard the term. So most predictions, as you've seen, the reason for things being canceled for 2 to 3 weeks are depending on the exact centers and the testing information. They're updating it, but we are probably about 2 weeks out from the anticipated peak.
Councilmember Agramonte is on the phone. Does she have questions? That's unfortunate. If she wants to text our city manager, okay. Has she texted you any questions?
We should just say, I don't think your microphone's on so the public doesn't know what you just said.
She lost sound, and Jeff did as well, Attorney Walter, and his came back, and we're actively working on hers now. She doesn't have a question except her sound yet, but I will let her know if she does, then we can text.
Okay, great. Another question I have is, when did we start looking for tests? I mean, when did we start requesting these tests from the CDC? Was this done months ago? When were we starting to push for this kind of stuff to come out? Because obviously, we'd like to have them as much as possible. I know that we're working as hard as we can to get them. When did we first start kind of making that request?
It's not really a request that we can make. This is our Department of Public Health, and it's for them to request from the CDC. It's not on a local basis. We have to go through our local Department of Public Health. So we've been in contact with them to get that information as it's become available. It has been the same for us as it has been nationwide. I couldn't tell you off the top of my head, but I want to say first testing in the U.S. really became available on the local level about 3 weeks ago, roughly.
Okay. And then just the kind of, do you have another question, Councilmember
Yeah.
Harrington? Go.
This isn't a criticism because obviously we're doing the best we can and we're so lucky we have a local hospital, and thank you for all your preparations. But given the age of our population, it sounds to me like it's going to be woefully inadequate because probably a lot of people already do have it. And so what happens then specifically? I know UCSF was setting up tents in their parking lot. I mean, obviously that depends on healthcare workers to staff those tents. And so what are we going to do? Because assuming it does come here, what we have right now probably isn't enough.
I think we really don't know. What we can do is follow the shelter-in-place advisories and do our best to avoid that and keep working with our partners. There is not a magic solution, so it's every day. It's all the things we've talked about. It's all the preparation. It's treating anyone who can be treated at home, saving those beds for the critically ill. It's only coming to the emergency department if you need emergency care and not exposing yourself or your loved ones to other illnesses. It's all of those things that we can do ourselves at this time that'll make a difference.
And can the shelter in place only be enacted once public health recommends that, or?
That is a legal question, and it's a conversation that we're talking about internally in terms of kind of just trying to understand. I think our goal is to work with the county to push and to continue to encourage them to be as aggressive as possible on the social distancing. So I am unclear
So I'd like to
legally.
know that.
I cannot answer that question for you.
I mean,
because-
later I would like to know the
yes.
answer. Because if 20% of this population, which is pretty senior, shows up at our hospital, it sounds like there's not going to be treatment.
I wouldn't say there's not going to be treatment, but we don't have enough ventilators for 20% of the population, but that's also not anticipated. The number that need ventilators are more like 2 to 3%.
Thank you. Do you have another question or? Can you just to reiterate, since we are going to send this out to the public, what are the kind of populations that we see that are at greater risk to this? What are the sort of respiratory diseases that we see that make you at greater risk?
So the populations that are greater risk, I think the age cutoffs vary, but on whole, around 65 or older in general. That is like mostly because older individuals tend to have what we call comorbidities, other medical conditions. The ones that specifically put you at greater risk are pulmonary diseases such as COPD, chronic asthma exacerbations, underlying cancers, and underlying heart disease are the main ones. Diabetes has also been mentioned, but that's also highly variable. Well-controlled younger diabetics probably not near as much risk as older, poorly controlled. So it's a spectrum.
And what are the main things that our public can do to flatten the curve, as we say?
Stay at home, stay at home, stay at home. Wash your hands, and don't touch your face. And I think that's about it. Video conference, work from home. Really, just the self-isolation is key. If you don't have contact with somebody, you can't spread it.
And do you have a message for younger members of our community that feel, because they're not at higher risk for this, that it's okay to go out and...
Although younger members may not become ill from this, there's a lot of evidence that you may be asymptomatic vectors, and we don't know the degree of that. So you are equally important to the shelter in place and the survival of your older members. So some of the best guidelines I've read and trying to follow myself is stop treating the disease like you don't want to give it, or like you don't want to get it, and start treating the disease like you have it and you don't want to spread it.
Thank you. And I will say, for both myself and my wife and everybody in this community, but we grew up here, and so these older members of our community are our parents. These are our grandparents. These are extremely, extremely important people. These are loved ones to all of us. And it's very, very important that all of us work together to make sure that we flatten this curve, and we do everything that we possibly can to reduce the harm and the spread of this disease, because these are extremely important people in our community. These are people who matter a lot, and let's all work together to make sure that happens. Thank you.